This is the story of a 53-year-old foreign national who presented to our outpatient department. He came with chief complaints of right eye, pain, redness, and irritation since a week, along with headache and giddiness. On further probing, he gave a history of stomachache and vomiting a week ago. He was suspected to have gastroenteritis after consuming food at a restaurant. On examination, circumcorneal congestion along with 3 plus cells was present. Fundus revealed blurred disc margins with splinter hemorrhage. Curvilinear scars were seen in the inferior nasal quadrant along with infiltrates in the vitreous. Differential diagnosis of retinitis with vasculitis, endogenous endophthalmitis, and peripheral polypoidal choroidal vasculopathy was made. Empirical therapy was instituted and patient was called for further evaluation along with serology. Serology revealed raised ESR and CRP, pointing to an underlying inflammatory pathology. Fluorescein fundus angiography revealed choroidal rupture or RPE rip-like curvilinear scars in the inferior nasal quadrant mid-periphery. On the 8th day since he first presented, 4 plus pigments were seen in the anterior chamber as well as on the anterior lens capsule. Moreover, the intraocular pressure measured was 30 mm of mercury. He was diagnosed with steroid-induced ocular hypertension and appropriate therapy was initiated. The intraocular pressure was 40 mm of mercury despite the patient being on multiple anti-glaucoma medications. Patient developed corneal edema secondary to the raised intraocular pressure. Anterior lens capsule pigments also increased. OCT revealed florid vitritis with posterior vitreous detachment. The B scan was also suggestive of vitritis. A right eye vitreous biopsy was done to get a clue regarding the diagnosis of this mystifying puzzle, but it revealed no further information as the reports came back negative. Fibrin membrane formed in the anterior chamber, whereas the lens revealed early cataractous changes with a streak hemorrhage and a curvilinear track in the lens. Fundus pictures started clearing as evidenced by the resolution of streak subhyaloid hemorrhage and regression of the exudate clumps. Anterior segment OCT was done, which, to our surprise, revealed the presence of an intralenticular worm. To the best of our knowledge, this is the first reported case of an intralenticular worm. The lens opacified further, leaving a very hazy view of the fundus. The worm was then evidently appreciated on the background of opacified cataractous lens. The worm was seen at different positions at each examination, indicating that the worm was mobile and thus alive. Surgery was planned to remove the same. Pre-op serology revealed raised serum IgE levels, as would be expected in a parasitic infection. Under low microscope illumination and through a temporal tunnel, anterior lens capsule was nicked away from the worm. The worm was carefully maneuvered from the lens into the anterior chamber. Care was taken to ensure it was removed in toto. It was sent in basal salt solution to the pathology lab for analysis. Capsular excess was started at the site of the existing capsular nick. Further steps carried out as routine small incision cataract surgery. Rest of the surgery was uneventful. The patient was left aphakic. Intravitreal vancomycin, ceftazidime and dexamethasone was instituted. Immediate post-operative anterior segment is seen here, along with posterior capsule as seen on the anterior segment OCT. On light microscopy, Gnathostoma spinaegarum was identified, showing characteristic anterior cephalic hooklets and cuticular spines. The post-operative management was also a challenging task, as the scarring subretinal lesions left by the worm's tracks led to a tractional retinal detachment, which had to be resolved by doing a pars plana vitrectomy along with perfluoropropane gas tamponade and endolaser. The epiretinal membrane was also peeled off. Through a temporal clear corneal section, a secondary acrylic intraocular lens was implanted. Unembryonated gnathostoma eggs are released in the feces of definitive hosts like cats, dogs, or pigs. These get embryonated in the water and subsequently release the early larvae, which are in turn ingested by a variety of hosts and they eventually grow into the advanced larvae. When humans eat undercooked meat or fish, there is a chance of getting infected by the advanced larval stage of Gnathostoma. Human beings are not the natural hosts of Gnathostoma, thus, it does not undergo further maturation once inside the human body and stays in the advanced larval stage. The bulbous head and rows of cuticular spines can cause significant damage and inflammation as the worm migrates through cutaneous or visceral larva migrants. For instance, the intestine, the liver, the lung, or even the eyes. After ingestion, the advanced larvae probably first reaches into the intestine and the liver tissues, thereby causing a gastritis like presentation. From here on, they can migrate to almost any organ. For this particular case, we hypothesize that the larva, after penetrating the gut, traveled via the bloodstream to the highly vascular posterior segment of the eye. Here, it traversed along the choroidal tissue as evidenced by curvilinear scars in the fundus. It eventually reached the iris ciliary body area wherein it is assumed to have emerged into the anterior segment as proven by the sudden appearance of pigments in the anterior chamber. It then probably nicked into the lens capsule and gained entry into the lens, causing the lens to opacify. Eventually, it got lodged between the cortex and the anterior lens capsule and was grossly visible to the naked eye. The patient is flying back to his country with a smile on his face after successfully persevering through this unusual ordeal. A worm's eye view is useless if you cannot find your way around. The eye-catching worm infestation can be prevented by following basic hygiene practices, cooking food properly, and by regularly deworming pet cats and dogs. It is imperative to keep our eyes and minds open and never lose hope while searching for a puzzling diagnosis.